Thank you so much for inviting me to be part of this training program. It's a really important topic. So I'd like to introduce a little bit about myself and my background before we get into the meat of my presentation. I have been an anesthetic specialist for more than 25 years. So I've seen my fair share of trauma, resuscitation, medical emergencies, and so on. I now work full-time as a trauma therapist in my own clinic in Raglan. So I've learned a great deal about the science of trauma and the kind of issues that my clients are presenting. In the last week, I've been approached by 4 clients who have all lost family members to suicide and are seeking help with the trauma of those events. So I can share with you some of my experiences. About 20 years ago, I was confronted with the very sudden death of a mother I was caring for. This was a lady who walked into the hospital and a few minutes later collapsed into coma with a brain hemorrhage. And I rushed her to the operating room, and together with the surgeon, we were able to save a baby who was delivered with no heartbeat but was resuscitated and became well. But the mother, at the end of the surgery, was brain dead. Her pupils were fixed and dilated. And I was the one that had to go out and speak with the husband and tell him that his wife almost certainly had died, would be brain dead, and was not going to recover. Um, and kept in touch with the family after that time in support. And at that time, I began to reflect on the state that I was feeling in myself the next day when I came at work, and realized that I was actually not really in a fit state to be caring for patients. I was deeply upset and traumatized by this very sudden death of this young woman that had walked into the hospital right in front of me. And as I reflected on that and many prior events, I realized that for the first time in my professional career, I should actually stop work. I should take some time off, and I should attend to my trauma and my suffering and my grief and my loss. And I phoned the head of department of anesthesia and said, Andrew, I'm really upset about this sudden death of this mother, and and I know that we cared for her really well and did everything possible. I don't feel bad about that, but I have a weight of grief and trauma and loss, and I need to take some time off. And he said, that's great, fine, whatever you need. How much time? And I said, I want to take 2 weeks off work. And that's what I did. And that was the first time in my whole career when I'd begun to reflect on the losses that we experience and the grief and the trauma we experience in the first line, in doing work to try and rescue and help and save people. And when I thought back through my entire career, this death of this mother was one of only of 31 deaths that I could remember. I could remember individually patients that I'd cared for, including 6 who died on my first weekend as a doctor, that that I had never grieved for. I had the rule in medicine is just to keep going, push aside your feelings, get on with the next case. The culture within medicine is never to admit vulnerability. It's never to share with any of your colleagues that you were traumatized or upset or struggling with these issues. We just had to be superheroes. And indeed, I was a superhero in many ways. I trained 14 years to be a doctor and then an anaesthetist, and I was doing major trauma work in the biggest hospital in New Zealand and indeed saving many lives. But those of us in those emergency heroic professions, like in medicine or in first responders, the many different the ambulance officers, the paramedics, the volunteers, the fire volunteers, just the police, every one of us in those front lines that are encountering these very traumatic events, we tend to have a rather heroic culture where the professional culture is never ever admit to your vulnerability and keep quiet about it and just carry on and do the job as if we have to become like automatons, like robots, and not admit to our feelings. And that time 20 years ago when I was in my 40s was the first time I thought, no, this is actually harming me. This is not right this is making me into the kind of doctor that can't provide the best care for patients. So I want to explore all of these issues, and I want to bring a particular focus to the role of first responders when you respond to a completed suicide event. Because not only are you faced with the trauma and the violence and the horrible sights sometimes that you encounter in those circumstances, but you have other people to care for as well. You have family members and colleagues and others who are traumatized and grieving and shocked. And our job extends much more than just trying to save the life of the individual. And when we don't process our trauma and our grief and our loss, we become impaired in our capacity to provide that emotional and compassionate support to others. And we become a little bit less human, a bit less effective. And that impacts on the quality and safety of our technical care as well. So I want to explore all those issues. So 3 years ago, I completely quit my medical practice, and I now work full-time as a trauma therapist. And I'm using a very particular form of therapy called havening techniques, which is based on a very detailed neuroscientific understanding of what happens in the brains when we get traumatized, and what the impact of that is on our lives. How it affects our thoughts, our beliefs, our stress responses, our emotional reactions, our body symptoms, and a whole pile of other things that can really have a major impact on our lives. So I want to explain to you something about the science of trauma, because if we can understand that, then we can understand better why it's important to address this in our own lives, and the benefits of that, and the great potential to seek some help and really get some really profound healing very quickly, even from very major traumatic events. And I certainly have experienced that in my medical career. I've witnessed some really terrible and distressing and awful traumas, and I'm now able to leave those in the past. They're no longer traumatic for me. I've had therapy for those. They're gone. Then they're no longer in my brains. I can look back and remember those events factually, but I don't have any distress connected with them anymore. So havening techniques is based on the work of a New York doctor and researcher called Dr. Ronald Ruden. He's a medical doctor and an internal medicine specialist. He's 75 years old. He only just retired from medical practice at the end of last year. And he became intensely curious about 20 years ago about what happens in the brain when we go through a traumatic event, and how is that event stored in our brain. How is it possible that we can witness one event in life and be impacted by that for the rest of our lives in a way that might cause acute anxiety or depression or stress or flashbacks or triggers? How does this work? And he pursued this question relentlessly over a number of years. And in 2018, he published a scientific paper that describes the complete neuroanatomy and molecular mechanisms of how trauma is stored in the brain. And in the course of that work, discovered an extraordinary potential for rapid healing or cure of that trauma. So what he found out is that during a traumatic event, and seeing the result of a completed suicide is certainly that. I'll come later on to the technical definitions of what a trauma is, but that's certainly a potentially traumatic event. That during those events, we have a very major stress response. Our brain is filled with very fast brain waves called gamma waves, and there are enzymes within the nerve cells in a part of the brain called the amygdala, and this is where trauma is stored. And these enzymes respond to a very high frequency oscillation of calcium ions, and that triggers a whole pile of molecular mechanisms. And what that does is it pushes receptors up to the cell surface of a cell membrane. And receptors are the means by which nerves connect together and send signals to each other. So in a matter of minutes, receptors are pushed up to the cell membrane, and then they're superglued. They're locked in place with a chemical bond, and then remain there for the rest of your life. And we form a traumatic memory. And this molecular reaction occurs within just a few minutes. It's extremely rapid, and then the effects are lifelong. So the amygdala is part of our safety system. we're experiencing about 11 million bits of sensory information a second, and the amygdala is scanning all of those to look for anything that might be a threat. And it remembers past events that were threatening or the traumatic and is ready to respond like that. It's like an emotional immune system. So when any information comes through our senses that can act as a subconscious trigger, it might be a certain sound or sight or location or any kind of sensory information, an image. When that sensory information comes in and is analyzed by the amygdala, it can respond within 75 milliseconds. That's 1/15 of a second. That's 4 times faster than the thinking part of the brain comes online. So when a traumatic memory is reactivated by subconscious stimuli, then it activates a number of neural pathways that are tightly hardwired linked into these circuits in the brain. So it generates a whole pile of images, of flashbacks, of memories. It generates beliefs that occurred as the result of this trauma. It activates our autonomic nervous system. So it activates our fight or flight system, sympathetic nervous system. Or if it's extreme, we might go into the reaction of being kind of frozen, completely powerless, helpless, frozen, unable to move. And that's the dorsal vagal part of the parasympathetic nervous system. So it activates those elements. Whatever body symptoms we have and body experiences at the time of the trauma are stored also like a computer backup. And our emotional response, all these elements are stored in very great detail like a computer backup. And that's a traumatic memory. And when it's triggered subconsciously in a tiny fraction of a second, that recreates our thoughts, our images, our stress responses, autonomic responses, body experiences, and emotional responses. All of these reactions are triggered completely automatically, and they're hardwired in our brain. We cannot think our way out of this. We're helplessly at the mercy of this. This is a reflex response, a hardwired response between a sensory input which acts as a trigger and the outflow of the traumatic memory. And that's going to be lifelong. So, for instance, I have clients, female clients that have been the subject of maybe a violent rape. And then every single thing about the setting, the context, the time of day, the tone of voice, the smell of the aftershave, even just the presence of men may be triggering. So I had a client lately who was completely unable to go shopping in a Bunnings warehouse because when she turned the corner into an aisle, she'd suddenly meet a strange man and she would get a huge fear response. And for quite a number of years, she'd been unable to go into that shop because the mere presence of a man was enough to trigger the memory of this horrifying attack that she'd experienced. And this was going to affect her for the rest of her life. This event had occurred 7 or 8 years before. So that's the nature of traumatic memory, and the memory is formed by forming lots of new nerve connections in that part of the brain called the amygdala. What Dr. Ruden discovered, which is just such an astonishing discovery, and I think he should win a Nobel Prize for this, is that in the course of this research, he discovered that if you activate one of these neural circuits, which is the trauma memory, and then you flood the brain with very slow brainwaves, extremely slow delta waves, maybe 1 cycle per second or 1 cycle per 2 seconds, very slow. The only time we normally have high levels of delta waves is during deep sleep, which is a time of healing and replenishment. So if we flood the brain with delta waves, then the enzymes within the nerve cells that are frequency sensitive, they bind in a different way to calcium ions that are oscillating at this low frequency, and it activates an enzyme that dissolves away the superglue bond that was holding the receptor in the cell membrane. That's dissolved away very quickly. The receptors become free in the cell membrane, and then they can be grabbed by the molecular mechanism within the cell and pulled into the cell and then disposed of. And this molecular reaction occurs for 5 to 7 minutes. So in my practice as a healing practitioner, the client maybe who had the very violent rape, I can ask the client very briefly to recall the memory of that without ever having to tell the story. We then induce delta waves in the brain using very specific forms of touch. And we take the client's mind away from that horrible memory by a variety of humorous mind games and distractions. And the very specific forms of touch that were discovered by the neuroscientists activate the delta waves in the brain, and that activates the enzymes that dissolves away the superglue bond, and the receptors are removed from the cell membrane, and all the connections are lost. So all of the nerve connections that hardwire the trauma are just completely gone, sometimes in less than 10 minutes. So the result of this is that when the same sensory information comes in, it just has no response whatsoever. So the client that had the attack from a man that couldn't go into Bunnings reported that she could now go to the Bunnings, and she spent an hour walking up and down the aisles meeting strange men and not getting any kind of a fear response, because the wiring that connects that sensory input to the trauma is just completely disconnected. So that's gone. So this is the nature of how trauma is stored in the brain and how we can take it away with havening techniques. And I'm going to share more about that. So as first responders or health professionals or anyone in this kind of work, what happens to us if we have unresolved trauma? And I'm pretty sure that all of us do, because that's the nature of our work, and it's also the nature of our professional culture to not address this. So what happens is that we have multiple triggers, and the more traumas we have, the more of a burden that we have that causes us anxiety, fear, triggered emotional responses, body responses, stresses, and many things that are the context of our work. It might be the sirens going off, or the pages, or the phone calls in the night. It might be certain locations, a road where you saw a horrible accident, a house where you saw some the result of some terrible violence or a suicide. It could be many, many different aspects. It could be putting on the uniform. It could be going into the station. It could be, for me, it was the last clinical work I did was in a small hospital working in a surgical unit. And when I opened a door and climbed 4 flights of stairs to an operating room, at the beginning of each day, I got this really big stress response, completely subconscious. My muscles would tense up. By the end of the day, I'd be feeling, kind of stressed out and tired. And I wondered why, because the work itself was pretty relaxing. It was just day surgery, no emergencies, no on call. And I figured out by being a detective that this particular trigger of climbing up 4 flights of stairs up to an operating room was a feature of a trauma from 35 years before, when I was a junior doctor and sent to the operating room to do operations unsupervised, which is completely terrifying. And in that hospital, there were 4 flights of stairs leading up to the operating room. And that was triggering a completely subconscious stress response in me. And the consequence of that is that I was stressed every single day at work when there was nothing about the work itself that was causing stress. This is a triggered response from before. And I reached out to a colleague. I had some havening, and we dissolved away the traumas of those experiences some 35 years ago. And the next day at work I arrived, I was relaxed. So if we have unprocessed trauma, we're going to get a lot of fear responses, a lot of stress responses. We're going to get high blood pressure. We're going to get a lot of cortisol. We're going to get reflux. We're going to find ourselves reaching for things to dampen down our unhappiness or anxiety. It, might be binging on Netflix or overeating or alcohol, or there are lots of different ways that we try and dampen down this inescapable stress that's within ourselves. And it impairs our capacity to be the best professional, because when we have these stress responses, the only way that we can respond is to dissociate, to numb ourselves, to become disconnected. And then we just become a robot. And we can be highly efficient in doing the emergency procedures to try and save someone's life. But that's only a small proportion of the work that we have to do. And if we can bring all of ourselves mindfully and our compassion and caring to our work, not only to those that are injured or sick, but the people around them, the families, the other people we have to deal with, then we can make an enormous difference to people's experience of events. And compassionate caring can make an enormous difference to the chances of survival of a trauma victim. It's shown that it can reduce bleeding, it can enhance survival. I mean, these are not small effects. So if we're living with a lot of unresolved trauma, we're really impairing our capacity to be the best kind of first responder or professional, and we're paying a very high cost in our personal life because of that inescapable stress. Now, this particular training program is about a very specific subject, and that's dealing with the bereavement, the grief and loss around suicide, and our role as first responders. And I think it's really important to understand, to pull apart the different elements here, because grief and sadness and loss are different from the trauma of events. And this is something I have to explain quite often to clients. Clients who have lost their loved ones, sometimes in quite traumatic circumstances. They might have witnessed a really horrible attempt to resuscitate at the end of life. They might have seen someone died at home and witnessed a resuscitation then. They might have seen a loved one die in a horrible accident and seen them maimed and injured. These are the things that we're going to witness as first responders, as health professionals. We're going to be in some places that are where there is a loss of a life, there's a loss of a human being, but there's also trauma involved. Now, as first responders, you're working in smaller communities very often, and so there's going to be a possibility that the person you're asked to attend to might be someone you know. It might be a friend, it might even be a family member. It certainly is going to be someone within your community. So the impact on us personally can be greater, and we can feel a great sense of grief and loss and sadness about the loss of someone. But what I see in my clients is that when the death has been traumatic, that their grief is complicated. A year and a half, 2 years later, they're still not able to grieve properly because the only image they can remember of that person that they've lost is that horrendous final image. That traumatic image and events are just stuck in their mind, and they get re-triggered every time they think of that person, and they're not able to grieve. So in my havening work, I explain to clients, I'm never going to do havening to try and take away sadness or grief, because these are the healthy ways that we deal with a loss. And we need to go through these processes, and they take time, and they're healthy responses to loss, and this is how we heal from a sad loss. So I don't want to interfere with that process, but what I want to do is help take away the trauma. And this is where havening practice can be just deeply helpful, because we can take people back to those moments of trauma, and we can dissolve away all of the nerve connections in the brain that hold those images, those experiences, those emotional reactions, those body responses. And very often when I've done that and the trauma is gone, I can then invite the client to share some happy memories of their lost mum or sister or brother or whoever it was. And very often the presence of that person comes really powerfully into the room, and we can invite the client to speak to the lost one and to say the things that never were able to say, and to hear back some things that the dead person wanted to share as well. And that can provide some really powerful, beautiful resolution and sense of closure. And then the healthy process of grieving can continue through that process of grief and sadness, and we heal from our losses. So it's very important to make that distinction. So havening therapy or havening techniques it's a practice done by practitioners like myself. There are now more than 60 certified havening practitioners in New Zealand, and I'm going to share with you at the end of this video some links to resources, how you can find some help. It can also be used as a self-healing technique, what we call self-havening. And on YouTube I have a whole variety of guided self-healing processes using havening techniques, and I'll give you the link to those. People have found them very helpful. They've been watched many hundreds of thousands of times, and in the comments people are saying that's really helpful. But I think in this case, as a first responder, if you're dealing with the trauma of dealing with a loss through suicide, then that's a time you should really seek the help of a qualified practitioner, a certified practitioner. And someone like myself can probably, in just one session of therapy, we can take you very quickly through a process. We can dissolve away the trauma of that events, and then you're left free to have a healthy process of healing through grief and sadness, healing from that loss. So I wouldn't recommend that you try to do self-therapy around these very traumatic events. You need the compassionate care and presence of another human being, a practitioner, to guide you through that process. So if we can reach out for some help and dissolve away, heal our traumas, then we can come into much more compassionate and powerful and effective process. And I want to share a little bit about that. So I was at a conference in San Francisco on compassionate caring in healthcare, and some researchers there came up with a very helpful concept that I hadn't heard before, which is called flexible empathy. So I want to give an example of how that would work. So as an anaesthetist, I've worked in many rural hospitals, little places like Greymouth on the west coast, and I might be called down to the emergency department to do a resuscitation of someone who's critically ill. And like you, in those moments, I have just a few minutes to make an assessment and carry out the emergency procedures that might be able to save a patient's life. And in the rush and the urgency of that, I don't have the time for my emotions to get in the way, right? So we want to be totally focused on mentally, cognitively, our physical skills and tasks and getting that life saved. So it's having, most of us have fairly practiced at that, okay? We're really good at just disconnecting from our feelings, being the hero, getting the stuff done. So we know how to do that. What many of us haven't figured out is that when we've got the patient stabilized, resuscitated, we then have to go meet with the family, right? And we actually need to be a completely different kind of professional at that moment, because what they don't want to see is the detached clinician. They don't want to see the person who's going to explain all the technicalities of the injuries or the resuscitation or the treatments given. They're people in shock and trauma who are extremely upset and worried and afraid and traumatized, and what they need is a compassionate practitioner. So you need the mental capacity to switch off all the kind of cognitive detached stuff and bring your open heart of compassion and warmth, and to speak with the family and to offer them a hug and to offer emotional support and validate their feelings, and then explain in simple language what's happened and what's going to be happening and what might happen, and offer support and communication. So it's these dual aspects of care. It's the technical care and there's the compassionate care. And the ability to flip between those, to mindfully be aware of what kind of mental attitude, what kind of role we want to use in the particular circumstance, that is called flexible empathy. There's been a lot of research done around how powerful it can be for first responders to know about compassionate care. And the world authority on this subject is someone called Judith Simon Prager, and this is her book called The Worst Is Over, Verbal First Aid to Calm, Relieve Pain, Promote Healing and Save Lives. And this is a manual for some very precise words and actions we can do when we're in that emergency situation, on the roadside, in the home, wherever it is. We can offer our empathy, our compassion, we can touch someone, we can hold a hand, and we can offer highly specific words that allow someone to feel calmer, to feel safer, to be reassured. And the research shows that this makes a very substantial difference to blood loss. It makes a substantial difference to the chances of survival. It makes a substantial difference to the emotional experience of that person, and whether that person actually gets traumatized by that accident or injury or illness, or whether they actually recover from it. Because the hallmark of trauma is being completely alone in your suffering. And if you have at least one person who's emotionally available, who's with you, who will hold your hand, who will talk to you as a human being, who will be comforting, who will be kind, who will reassure you, that can prevent traumatization from occurring. So you can get through a really difficult life event without being traumatized. So we're mental health practitioners as well as technicians, doing our resuscitation or our care. And this is why it's so important to attend to our trauma, because if we have a lot of unresolved trauma, our hearts are closed over, and we're not able to offer that degree of compassionate care. And that actually impacts on the technical quality of care, it impacts on our clinical outcomes, and we're not as full or as great a practitioner as we can be. At the end of this video, I'm just going to share a pile of resources. I'm going to share some resources from my own website which explain about what havening is, what trauma is, who I am, how I work, how we can put all this together. My clients find that extremely helpful. Some other learning resources, and just to encourage you to be like me 20 years ago. I was the first ever doctor to take sick leave because of emotional distress. No other senior doctor had ever done that. And part of the reason I chose to do that was not only for my own well-being, is I wanted to set a precedent that it was okay to be vulnerable, that we actually need to attend to our own health and well-being if we're going to be the best practitioners we can be, and to set a precedent. So within the culture of emergency services, that's a difficult thing to do, but I really want to encourage you. And if you as an individual can be courageous enough to talk about your experiences, to talk about your struggles, to talk about your trauma, to go out and seek help, then not only are you going to be helping yourself, but you're going to be giving others permission to talk about their own stuff, to open up. And we're going to start to create a culture change within the organizations, and that's really important. So I encourage you to do that. And thank you so much for asking me to contribute to your training program. And I'm always happy to be contacted and to answer any of your questions. And I have a number of first responders and ex-servicemen and policemen and other among my clients who've been courageous enough to come and seek help, and they've received great benefits. So I hope to see a lot more. So thank you very much.